Hi, I'm Dr. Ed Weisbart. I am a family physician. I am the National Board Secretary for Physicians for a National Health Program, and I'm the chair of the Missouri chapter of PNHP as well. Probably know PNHP is a nonprofit, nonpartisan 501c3 organization that advocates and educates around single-payer Medicare for all. And I want to thank Healthcare Now for inviting me to speak to you about the fight that we're having for Medicare for all, in particular, the fight against the privatization of traditional Medicare. So today we're going to talk a bit about Medicare Advantage, about ACO REACH, and a little bit about what we should do about these things. Before we get to that, we'll of course explain a little bit more about what Medicare is and why it's such an incredibly important program, why it's a good idea as a program for a basis for Medicare for all single payer, and why these attacks are so important to all of us, even though they're not fully recognized. To get there, though, I want to start by introducing you to my family. This is my mother-in-law, Pat. And if you're a HIPAA-centric person, not to worry, I have Ma's permission to tell you her story. So Ma lives in Florida, and she has Medicare, hence the connection here, and she has traditional Medicare, Parts A and B, and Medigap. So you'll hear me say the phrase traditional Medicare. You'll hear other people say the phrase original Medicare. Those are synonyms in case you're confused. And both of those refer to Parts A and B of Medicare, which were created in 1965 when the law was first passed. So she has that. She has traditional Medicare and Medigap to make sure she doesn't have to deal with copays and deductibles. And we'll unpack both of those things a bit more. But she also, unfortunately, has a rare genetic disease of her heart. And this is something that doesn't usually show up in the advanced years in life. It's usually younger. So it turns out it's pretty uncommon for someone in her age group to have this show up. And being uncommon, there's literally no medical group in Florida near her that focuses on treating this, and it must be treated because it's progressive and ultimately, makes you very miserable and ultimately fatal. So nobody in Florida. So we flew Ma to St. Louis, where I live, and because it turns out that in St. Louis, at Washington University of St. Louis, there is one of the 3 centers in the country that focuses on treating this in her age group. So we flew her here. She got arguably world-class healthcare. Spent several days in the hospital, then a few weeks kind of recovering here with us. And then she flew back to Florida. And this was, I think, 7-8 years ago, something like that. And she has since had 2 orthopedic surgeries and is thriving. She probably would not be doing nearly, she probably wouldn't have lived through the cardiac problem that she was having had it not been treated, let alone had cardiac surgery. So she has traditional Medicare, which means she can go anywhere that she wants. Has she made the mistake, frankly, of going into Medicare Advantage? Chances are she couldn't have come to St. Louis and had her healthcare paid for. We'll unpack that more in a few moments. But I'm the bloke who managed most of her course of care, and I never had to call anybody for permission. I didn't call Medicare. I didn't call her Medigap plan. I didn't call anybody to get approval. She essentially didn't need to get approval for this. Again, had she had Medicare Advantage, they would have required prior authorization and probably said, yeah, but not in St. Louis. She didn't pay a penny. She didn't pay a penny out of pocket. So that's, good for her. And she didn't have any surprises when she went home. As you know, a lot of people that have employer-based insurance, when they get home, from hospitals or from the emergency room, they have hundreds, if not thousands of dollars of bills that they frankly had no way of anticipating or preventing. She has Medicare, Medigap. She didn't have a single surprise bill. And she's, she likes this. She had it, for decades now, and she trusts that it will be there for her for the remainder of her life. So when she hears that people are doing things to mess with her Medicare, you have to deal with this version of my mother-in-law. And, I don't stumble into that very often, but trust me, you don't want to have to deal with that. So a little bit of news that you may have missed. Here's a headline ripped from the news. A milestone in finding better ways to improve well-being. Some quotes: financial incentive to keep subscribers healthy, shift the emphasis to the prevention of illness, test all over the country, and test specifically in medically underprivileged, to show some dating of this. This is not from one of the new cutting edge programs that we're going to talk about. This is from the HMO Act of 1973. And to be honest with you, this sounds pretty good to me, this stuff. In fact, that's one of the reasons I went to medical school. I was a zealot in charge in favor of managed care and HMOs, but the evidence in my experience has changed my point of view on that. But this is the value proposition of managed care, right? And let's explain that a little bit more. So first, my wonkiest chart. I promise you this is as wonky as it gets in the next chunk of time here. Here is data from 30 high-income countries. And I thank Charlie Swanson for having extracted this from World Bank data. Any of my charts like this one that have numbers on the bottom, there's a footnote at the bottom left corner where you can find the public domain and peer-reviewed sorts of references. So this complicated chart is 30 countries over 50 years. So each one of those different colored lines is a different country. Down at the bottom left corner in 1970, if you follow any one of those lines along, you'll get just about up until the pandemic started. So I'm sure the next chart next year when we produce this will be a little bit more distressing. But what you can see is over this 50-year period, life expectancy has gradually gone up everywhere, as has, of course, healthcare expenditures per person in US dollars. You might be wondering, well, which of these countries is the United States? Which line? Are we the blue one? Well, it's a trick question because we're not any of those lines. Here we are completely different from the rest of these other comparable countries. So the first obvious thing to notice is that we're not on, we're way off the chart here. We are spending roughly twice as much as these other countries, and we are living, our lives are cut several years shorter compared to what these other countries expect as their life expectancy. So that's the first obvious thing. The second thing to notice, if you look more closely, is at the bottom left corner in 1970, we were normal. We were normal. We were right in the middle of the pack, so to speak. And then we migrated away. So what's the difference from us to those countries? Well, the first big difference is that each one of those countries has some form of a national health insurance model. Everyone's different. They all have different names for it. Some would call it single payer, some would not, but they all have some form of guaranteeing that everyone in their country has affordable access to high quality healthcare. And of course, as you know, the United States is the one country of this group that has chosen not to do that so far. But it's not that we've been sitting idly by. No, we've been trying lots of things. So there's the HMO Act when we started to wander away from the pack. Notice how we deviated after the managed care was created. And I'm not going to explain each one of these different red boxes to you. Some of them are probably familiar to you. Some are not. We will focus mainly today on Medicare Advantage and on REACH. But they all have in common each one of these red boxes has one common theme that the other countries don't have, which is that the United States models for healthcare reform consistently rely on fiscal intermediaries, consistently rely on market solutions, consistently rely on systems that frankly enable and maybe even attract profiteering to divert our money away from actual healthcare, even though that's what we think we're paying for. So that's the difference: national health insurance versus market solutions that enable profiteering. So let's talk a bit about Medicare. I argue to you that it's frankly becoming an endangered species, and like all endangered species, we need to protect it. So here's the original Medicare card from Harry Truman when he first signed on. And you all know basically about Medicare, but there's three features of traditional Medicare that I don't think are adequately understood. The first is this has the fewest barriers to care and the broadest networks across the United States. The second is that it's incredibly lean and efficient and effective. And we'll show you some data about each of these pieces. So TERPs, first, that's the most obvious one in terms of the broadest national network. If you have health insurance, if you live in St. Louis and you have Medicare Advantage, or you have employer-based insurance, chances are you would have a hard time going to Florida and getting anything but emergency health care paid for. Whereas if you have traditional Medicare, and only traditional Medicare pretty much, you have access to Medicare's entire health network of physicians and hospitals across the United States, And so Kaiser Family last year asked physicians around the country, well, how good is that? Do you accept Medicare as a payment model? And frankly, nearly 90% of office-based non-pediatric, because pediatric doctors don't take it as much because there aren't too many kids, some in Medicare, but office-based non-pediatric physicians, almost all of them accept Medicare as a payment. Now, that's not all of them accepting new Medicare patients, because remember, a lot of physicians don't accept any new patients, but nearly 90% of office-based physicians accept Medicare as a payment model, and it's an even higher percentage. Virtually every surgical specialist accepts Medicare for payment. So you can go to nearly any physician and hospital anywhere in the United States. It's also remarkably effective. If you look at how well it controls the cost of healthcare, which is frankly the thing that we pay them insurance companies to do, here's 10 years worth of data looking at the growth and how much people spend on healthcare, how much is spent on healthcare across 10 years. And commercial health insurance, employer health insurance, basically the cost of healthcare has gone up by more than 50% over this 10-year period. Is that a lot? Well, it's more than double how much the cost of healthcare has gone up per person in Medicare. So Medicare does an extraordinarily good job at controlling the cost of healthcare, and it does this in an incredibly lean and efficient system. Traditional Medicare has a 2% overhead. 98 cents out of every dollar that goes into traditional Medicare actually goes to pay doctors and hospitals. There is no profit built into it, and it's got an incredibly tight overhead, 90, and that's all in. That's including a proportion of the IRS staff that collect taxes and the building, the bricks and mortar. It's all in. Apparently, 2% is the overhead. Really efficient. It also surprisingly makes us healthier, and I don't think they don't get nearly enough credit for that. And we could talk a lot about what that means, but this is one set of data from the Institute of Medicine that I think is pretty interesting. So you knew, I said it earlier, you knew that our life expectancies are cut several years, 3 to 4 years shorter than other nations. Here's that data stratified by age. So this is actually our rank in mortality rate. I think of it as life expectancy, but really it's our mortality rate compared to 17 peer nations. And if you put your head up to your monitor, you'll be able to see what those nations are. But 17 peer nations stratified by age. So children off to the left and the most senior among us all the way to the right. And just as you would expect from what I've been saying, there we are merrily holding up the bottom of the chart, number 16 or 17 or 15 sometimes out of in ranking, the worst in the modern world in terms of mortality rate by age, until the magic happens and we turn 65. And then country by country and year by year, we climb to literally the best in the world. So that means, we're doing something right in the United States. We're doing something right. We must have many of the world's best doctors and pharmacists and hospitals. We just must, or this would be impossible. The problem is we don't let everybody in. That is the problem. So what is the way that we don't let people in now? How are we letting it get ripped off and taken apart away from us? Well, traditional Medicare is really lean and efficient. And I'm going to show you just a simple cartoon. There we are on the left, and we pay, our taxes, and we get our red, white, and blue Medicare card, Part A and B, as you can see there, which we hold on to for our dear lives. And then Medicare directly pays the doctors and hospitals on our behalf as patients. Medicare Advantage, not 2% overhead, but 15% overhead. Medicare Advantage is really complicated. So it interposes all of these insurance companies and many more, and then Medicare no longer pays your doctor or your hospital if you have Medicare Advantage. Instead, Medicare pays commercial insurance companies, and then they pay your doctor and hospital. And so, of course, the less they pay, the less healthcare you wind up needing, the more of what Medicare pays them they get to keep. And so they don't want you to get healthcare. So I've made a simple cartoon where we pay, or we pay our taxes, Medicare pays the insurance companies pay the doctors and hospitals. It's one level more complicated because, of course, they'll tell you, the insurance companies tell you, oh, go to this doctor, not that doctor. Well, who are you to tell me which doctor I can go to? Go to this hospital, not that hospital. And remember, we are paying, that's their niche. We are paying the insurance companies to tell us which doctors and hospitals we can't use. That's the core model of Medicare Advantage. And it's complicated, and complexity is inevitably less efficient. So complexity is the opposite of efficient, frankly. So one of the things you see in Medicare Advantage that you don't see in traditional Medicare is the reintroduction of all of these HMO-style tools that we don't like. Prior authorizations and step therapies and a whole arrangement of things where you need to call Medicare, you need to call the Advantage company to get approval for healthcare that you and your doctor think you need. That's unique to Medicare Advantage. It's almost unheard of. There's a handful of things that traditional Medicare does that for, but it's almost unheard of there, and it's rampant through Medicare Advantage, all of these prior authorizations that delay care. Likewise, Medicare Advantage, as I showed you in my cartoon, offers smaller networks. As I alluded to, they don't want you if you're sick and need to use more healthcare dollars because they get a fixed amount. And if you're sick, that means they don't really want you. So if you can't get access to the care that you want in Medicare Advantage and you complain to them, I'm going to get out, I don't like you people, I'm going to switch out of you, guess what? The Medicare Advantage company doesn't view that as a threat. They view that as mission accomplished. They don't want you if you're sick, you're expensive, and they're paid on the average, not for the expense. And if you're healthy, if you're young and healthy, or you're not using much healthcare, that's the person that they want. So they have games to attract the healthy, and they don't want to cover that tertiary care hospital because that's where the sick people want to go. As a result of all this, they have remarkably high overhead and profits, and that's not enough for them. No, they have been accused and have settled with fine, been charged with fines and massive settlements for fraud. These are often very fraudulent-based organizations. So we'll come back to that. So it's growing. Medicare Advantage, depending on how you count it, is approximately half of Medicare today. For the most part, people choosing to do it. Some employer groups are more and more assigning blocks, but over to Medicare Advantage if they have to pay a retiree benefit. But that's still an emerging issue. For the most part, people in Medicare Advantage have chosen to do that, and it's now grown to nearly 50%. And Congress views that growth as a really important thing. Last year, most members of Congress wrote to Medicare. I wrote CMS there, and that's the Centers for Medicare and Medicaid Services. I use that in this discussion as interchangeable with the word Medicare. CMS is the administrative organization from the United States government that runs Medicare. That's the M, one of the M's in CMS. So the Congress wrote to CMS saying, older adults on Medicare Advantage reports this consistent satisfaction with their coverage and quality of care. They may as well have said, hey, this is a market economy and the market has spoken. People are going into Medicare Advantage because it's better and because seniors just love it. That's what Congress thinks. So not everybody thinks that. One of my favorite people in the universe, Dr. Don Berwick, from whom I've learned an incredible amount, a former administrator of Medicare, actually, along with various other things, has a different point of view about this. He made this analogy that I just love. He said, if an ice cream firm, so a metaphor, get it? If an ice cream firm can offer free ice cream because of a subsidy, we subsidize an ice cream firm company, and they can offer free ice cream because of a subsidy, well, its market share will grow against the firms that have to charge for ice cream. Get free ice cream? You're going to have a lot of the market. The cause is not better ice cream, it's free ice cream. Well, is that really what's happening? Is that an apt metaphor? Yeah, that's really what's happening. It's an apt metaphor. Medicare has been consistently overpaying Medicare Advantage plans above what they would pay for the same person were that person in traditional or fee-for-service Medicare. So if you look at this forever, MedPAC is the governmental independent government agency that advises Congress about Medicare. It's the Medicare Payment and Advisory Commission, and they're the universally recognized group that gives the best reports and analysis and runs up the data about Medicare's performance. And MedPAC every year produces this report. The one for 2022 just came out a few weeks ago. Said that this is their chart, and they said that this actually underestimates the overpayments. So consistently now we're paying Medicare Advantage plans roughly 6% more for the same person as if they were in traditional Medicare. In other words, we are subsidizing Medicare Advantage, and that's how they can offer some of the perks we're going to talk about. And that's, of course, why Medicare Advantage is growing, because we are subsidizing them. It's free ice cream. So how do they make their money? Well, we talked a little bit about fraud, that this is pretty rampant in Medicare Advantage companies, but I want you to notice that whenever you see in the newspaper an article about fraud in Medicare Advantage, notice that it's a settlement without the admission of guilt, that they accept payment of a fine without the admission of guilt. And that seems like just a little one-line sentence in the middle of the article. Yeah, they didn't admit guilt. Yeah, that always happens. Yeah, that always happens, because if they admit guilt, well, then there's a whole other cascade of consequences that make it more difficult for them to get a government contract. So you'll frequently see these big outfits settle for hundreds of millions of dollars, but not admit any guilt. Really, not admit any guilt. They cherry pick, as I alluded to. They want you if you're healthy, because they're paid for the average person in their program. And so they want the healthiest who don't spend at the average, but they also want to get rid of you if you're one of those sicker people. Because if you're sick and they're paid on the average, but your expenses are higher, well, then you're not just a patient, you're a liability. And then the last of the mechanisms we'll talk about how they make money is what's called upcoding. And they're paid per person, right? We said that twice now. They're paid per person, and they're paid more if that person looks like they've got a whole bunch of diagnoses, and they get paid less if that person looks healthy. Well, that in theory kind of makes sense, right? If they're paid per person and somebody's like, really sick, and they're going to be paid a flat amount, well, then yeah, you should pay them a larger flat amount. So that kind of makes sense. That's why that was instituted. But the reality is it created an opportunity for gaming. So Medicare Advantage companies are notorious for finding diagnoses in their patients that don't have any clinical relevance. And in traditional Medicare, a doctor seeing a person in traditional Medicare, they don't get paid more for more diagnoses. They get paid more for more procedures, perhaps, but they don't get paid more for more diagnoses. So Medicare Advantage is proud of the fact that they have more accurate diagnostic codes because they're paid for them. So that's not a fair apples to apples comparison. That's called upcoding, getting paid more for having more diagnoses that don't really need to be treated. And it's a lot of money in this particular game. So this is just the billions of dollars that have been paid to Medicare Advantage plans just based on their upcoding, again, coming from MedPAC data. So lots of money every year being drained, and they have never generated savings. Medicare Advantage plans, according to the reputable, independent, nonpartisan Kaiser Family Foundation, Medicare Advantage plans have never been shown to generate savings compared to traditional Medicare. In fact, the opposite is true. And it's a lot of money. It's hard to know how much is $1 billion. It's pretty hard to get your head around. So the estimates of overbilling range from 12 to 25 billion. That's more than the entire budget of NASA. That's more than we spend on the FBI or on the federal prisons. Take your pick of these. Every one of these programs, the annual budget is under attack whenever it comes up for renewal in Congress. And the Medicare Advantage overbilling, just the overbilling, one of the many strategies by which they make extra money, extra profit, that is bigger than any of these other numbers. Another one of their little gimmicks is that they're allowed to create secret rules to keep you from getting healthcare. So traditional Medicare has really well-researched, evidence-based guidelines about what is and isn't medically sensible. So, if you want to, try inhaling a helium balloon to treat your blood pressure, well, traditional Medicare isn't going to pay you for that. I'm just making something up here. So traditional Medicare has guidelines about what is medically acceptable based on evidence. So there are these things. Medicare Advantage plans are allowed to use those guidelines and shrink them down to a sub-fraction of the ones that Medicare created. So they're allowed to create narrower guidelines and say, oh yeah, Medicare says that's covered. We're not going to pay for it though. They're allowed to have secret proprietary rules to reject necessary care. And in fact, nearly 1 out of 5 of the claims that Medicare Advantage plans denied in the year 2019, 4 years ago, nearly 1 out of 5 of those claims would have been approved and not denied had the patient been in traditional Medicare. And I point out that's 2019 because, now we're hearing the last several months that artificial intelligence, no longer humanoids, but artificial intelligence companies are now writing these new rules to reject otherwise necessary care. And if you appeal the denial, you're increasingly likely to run into an artificial intelligence company or agency reviewing your claim. It then gives 100 of them as a batch to someone within the company to just sign off on. So, I'm sure in a couple, 3 more years, we're going to have a whole wealth of new data about how that's working out because this is emerging. So this has real life impact on patients. Medicare Advantage patients have cost-related problems accessing care. So in this, we're comparing people in traditional Medicare who have Medigap, and we will get to why that's so important. But people in traditional Medicare with Medigap versus people in Medicare Advantage. And if you look at it, 12% of people in traditional Medicare with Medigap had difficulty accessing care because of cost, but more people in Medicare Advantage did. If you're white, the numbers are a little bit more favorable, but still Medicare Advantage patients are significantly worse at accessing care due to cost. Hispanics, the problem is more striking, and as for almost every metric, for Black Americans, it's even worse. So that 1/3 of Black Americans in Medicare Advantage report problems accessing healthcare due to cost. And these numbers are even more dramatic if you look at people who are specifically either in low income or in poor health. They have even worse problems. And it shows up by where people go to get their care. So if you have an obscure diagnosis, if you have an uncommon thing that needs really specialized care, especially cancer, you want to go to one of the top, if you have appendicitis, most hospitals in your community are probably just fine for treating that. If you have an uncommon cancer that needs a very technically demanding surgery, you want to go to one of the top-rated cancer centers. So these are good examples of that. If you need part of a lung removed for lung cancer, or your colon, your stomach, or your esophagus, or a Whipple procedure, something I really don't ever need to have. If you need one of those, if you have Medicare Advantage, you are significantly less likely to go to one of the top-rated cancer centers because they're probably not in your network. And so you'd have to be paying, a much higher out-of-pocket expense if you have Medicare Advantage. Traditional Medicare patients can go to these places. As a result of all this, in the last year of life, which is typically when most of us are the sickest that we're going to get, people are more likely to try to leave Medicare Advantage. So before the final year of life, there's some migration back and forth. But during the final year of life, people are significantly more likely to want to get out of Medicare Advantage. But I do want you to notice that that's number, the bar chart, I drew it tall, but it's less than 5%. So, there are, full disclosure, there are a lot of people in Medicare Advantage who do well and are reasonably happy, are pretty happy with it. So I'm not here to paint the aspersion on all of these, but there's almost no way as a patient to predetermine whether you're signing up for a good one or a bad one. Is there a good one? There's no really good way to tell. So if you ask people, well, why did you want to leave? The main reason people in the last year of life want to get out of Medicare Advantage is because of what I've been saying. They have difficulty accessing specialty care in Medicare Advantage, and that problem doesn't exist in traditional Medicare. So, interesting report that came out of the U.S. Senate Finance Committee late last year, and they documented incredibly deceptive marketing practices within Medicare Advantage. And we've all seen this. You've seen the ads on the TV machine where some famous football star, now a little bit more aged, is telling you, go sign this up for this. Well, the Senate recently looked at those ads and other ads and found rampant deceptive marketing practices. If you look up the report, there's several examples. This is my personal favorite. Medicare Advantage plans send you this in the mail. And this looks like a tax form, right? It doesn't say Medicare Advantage in big letters on it. Actually, I'm not sure if it says it anywhere on there. It looks like a tax form. It's got a T-2, and it looks just like a tax form. And if you don't read it carefully, and if you're not, thinking about this, you'd fill it out and send it in. And then unwittingly, you would have signed up for Medicare Advantage, and they're doing this kind of thing all the time. And we've learned that about a third of people making the decision between traditional Medicare or Medicare Advantage turn to someone whom they think is a trustable, trusted, trustworthy advisor, an insurance broker. And I actually have a very trustworthy insurance broker, but so some of them are quite trustworthy. But follow the money, and look at the commissions that they get. So Medicare Advantage plans, if you talk to an insurance agent, and like I said, 30% of us do when we're making this decision. If you talk to an insurance agent, they make a $500 commission for signing you up for Medicare Advantage. If they instead foolishly sign you up for Medigap, they make barely more than half of that in commission. And that's a big difference. And Part D, a drug benefit, they don't make hardly bupkis on that. So if you talk to most insurance agents about guidance on signing up for a drug benefit, they will send you to Medicare.gov, where you can find pretty easy comparisons. If you ask them about Medicare Advantage or Medigap, they could do the same thing, because guess what? That Medicare.gov has great information, but they don't, because they want to be the one who signed you up so they can get this commission. Aside from how big these commissions are, these commissions keep happening. So you sign up with your agent for one of these, and if you don't change agents every year for, I think, about a decade, they continue to get an annual commission for having signed you up. It's a bit smaller, but it's a lot less work. And just by having you not change, they continue to get their skin in the game, so to speak, their bit of the pie. So they may call you and say, "Hey, want to go get a cheeseburger?" "Yeah, I'll call you back about that." And then they get their commission. Turns out that they're not doing such a good job as you might expect. Medicare, CMS last year sent out secret shoppers calling insurance agents, and they found out that most of them got inaccurate or insufficient information when they called the insurance agent. So they have a strong vested interest to mislead you by making hundreds of dollars more per year and maybe thousands over the next decade. They have strong financial interest to mislead you, and perhaps for that reason, or just lack of training, the vast majority of the calls to an insurance agent are either inaccurate or insufficient. My favorite example is this one, a direct quote from the Senate Finance Report, where the Senate was told, or I'm sorry, from CMS Secret Shopper Report, where the CMS was told by the Medicare Advantage insurance agent, if your medication is not on the formulary, your doctor could just tell the Medicare Advantage plan, and the plan will just put it on. So don't worry your little head. That's of course not true. Most striking, of course, to me is the opportunity of these companies to frankly profiteer off of us. So I alluded to traditional Medicare having a 2% overhead, incredibly efficient. Medicare Advantage plans have a 15% overhead in general. Some are actually a little bit higher than that. So if Medicare Advantage is so awful, why are so many people signing up for it? And I thought PNHP board member Jessica Sachs, Dr. Jessica Sachs said this night, at least, oops, shoot, oh, excuse me. Dear. I thought Dr. Jessica Sachs, PNHP board member from North Carolina, said this nicely, where she said, despite all of this, the low premiums and perks in Medicare Advantage might be attractive, to people who are not yet sick, but the situation changes when they develop an illness. So why do they join Medicare Advantage? Because traditional Medicare is imperfect. There's a 20% co-insurance for outpatient care. There's a $1,600 hospital deductible. Those two things can rack up pretty quickly. $1,600 deductible, you're hospitalized 2 or 3 times, let's say, if you're really sick, that can bankrupt you. If you need to go to a doctor once a year, that's 20% is probably not so awful. But if you're sick and you need to go to a doctor every week, 2 doctors a week, 20% co-insurance is pretty high. With no limit. Traditional Medicare has no limit on how much that can add up to. And traditional Medicare, isn't free. Traditional Medicare means you get Part A, but automatically, but Part B, the outpatient stuff, you have to pay a premium for that. And then that doesn't include a drug benefit. So there's another premium for a drug benefit. And then if you need to do something about that 20% outpatient co-insurance and that $1,600 hospital deductible and the no out-of-pocket, you have to do something about that, or you could be bankrupt by it. So almost everybody in traditional Medicare should and does, I think 90%, wind up with some kind of a Medigap plan. So you really have 3 options if you're in Medicare. Number one, you can just keep traditional Medicare, not get Medigap, not do anything else. But as I said, twice now, I think, that exposes you to medical bankruptcy. You could leave traditional Medicare and go into Medicare Advantage. You could do that. We're going to compare those 2 strategies in a moment. Or you might keep traditional Medicare and purchase Medigap. And you really need to if you can. And we'll explain how that's maybe not something you actually can do. So the reason you may not be able to do that is because of something that we take for granted. The Affordable Care Act introduced the idea of no pre-existing conditions. The Affordable Care Act said that insurance companies cannot refuse to sell you an insurance policy because you're too sick. Those of you who are old enough to remember before the ACA, yeah, they could do that. They could say, no, you're sick. We're not going to sell you a policy. Really? And now they can't do that. If you buy a plan through the marketplace, the Affordable Care Act, they can't ask you how sick you are, and they have to charge you the same premium they would charge anybody in your community with a few little variations on that. So we take that for granted now, but when we retire and turn 65 or get into Medicare for whatever reason, that protection of being able to get a Medigap plan, a Medigap policy, only stays there with you for 6 months in Part B, or if you go into Medicare Advantage for 1 year. But after 1 year in Medicare Advantage, you may not be able to buy a Medigap policy because they don't have to sell it to you. If after 12 months in Medicare Advantage, if you want to buy Medigap because you're worried about bankruptcy and stuff, if you go back to traditional Medicare, the Medigap policy company can send you a health survey questionnaire and decide, oh, no, that person has this, that, and the other thing. I don't want them in my mix. They're going to have a lot of medical claims. They're going to be expensive. So they could say no. They can just say no after 12 months, or they can say yes, but we're going to charge you 6 times as much as or whatever. No limit on that. So after a year in Medicare Advantage, even though you can go back to traditional Medicare, you might be trapped because you can go back, but you can't necessarily get Medigap. It's a big deal, and most people don't realize that they're making that decision. So let's compare Medigap with Medicare Advantage. What's the trade-off that you're making? So Medigap, I'm going to talk about a Plan G because that's the one pretty much everybody is getting these days. So Plan G is the flavor of Medigap we'll compare it to Medicare Advantage, which is Medicare Part C, if you care. So, and if you get Medigap, Plan G, you don't get any extra benefits, right? Traditional Medicare doesn't cover dentistry. Getting Medigap doesn't add in dentistry coverage. Traditional Medicare doesn't offer a pharmacy benefit. Medigap doesn't give you a pharmacy benefit. You have the exact same benefits, no more or no less, by by purchasing Medigap, whereas Medicare Advantage does often include a lot of extras. A pharmacy benefit without you having to buy a Part D benefit, hearing exams, maybe hearing aids, vision, dentistry, a variety of things, which add up to about $2,300 value if you used all of them, but nobody uses all of them. But some real stuff on there that people appreciate. having, which you don't get in traditional Medicare, even with Medigap. So Medigap is the loser if you're comparing those features. Out of pocket, Medigap, yeah, there's nothing out of pocket. You pay your part of the copays and deductibles that I told you for traditional Medicare up until the Part B deductible is exhausted, which is $226 in the year 2023. So after you've hit that deductible, you have nothing out of pocket if you have traditional Medicare and Medigap. So there's not a limit because there's nothing, it's zero beyond that. Whereas with Medicare Advantage, your exposure is $8,300 per year. You can rack up $8,300 in out-of-pocket expenses in network. And if you decide that you need to get care outside of the Medicare Advantage network, it's limited to more than $12,000. So if you need a lot of care in Medicare Advantage, it can add up to quite a bit. So out-of-pocket expense, I'd say that Medigap with traditional Medicare is the winner. Utilization management, none of that, like I was saying, in traditional Medicare, almost none of it. Whereas in Medicare Advantage, it's like everywhere. It's their core business model these days. So yeah, that's another problem with Medicare Advantage networks. Medigap in no way alters the robust 89% of physicians who will accept you in outpatient care across the United States. Medigap has the same, it doesn't change your network of traditional Medicare, whereas Medicare Advantage has a much smaller list of in-network physicians and hospitals, typically only in your geography. So I'd say it's a loser there. But perhaps the one that people look at and don't look any further is the premiums, the monthly premiums. So the average monthly premium for a Medigap policy in 2023 is about $200. The average Part B, or the baseline Part B premium, according to Medicare for 2023, is another $165 a month. And a Part D benefit, according to Medicare data for 2023, is averaging $32. And if you add those up and multiply it by 12, that's nearly $5,000 a year. So if you decide to stay in traditional Medicare because you want to avoid those red boxes on the right, including avoiding that $12,000 out-of-pocket expense, you have to pony up roughly $4,700 per year in premiums. Whereas in Medicare Advantage, the average is $18 per month for Medicare Advantage, and that almost always includes a drug benefit with no extra premium, and it often includes the Medicare Advantage plan even paying your Part B premium for you. Not always, and sometimes and sometimes not, but for a lot of folks, Medicare Advantage is on average $18 a month, or that's an average. So for a lot of folks, like for myself in Missouri, I could have joined Medicare Advantage for free, and instead I'm paying $4,700 per year for myself, or really, nearly $10,000 a year for my wife and myself, because those red boxes on the right and my philosophic aversion to profiteering made me decide, that I wanted to do that. So that's the trade-off that you're making. So traditional Medicare with a Part B, because you have to have you really need to get Part B, and with a drug benefit Part D, and with Medigap part of Plan G, is $4,600 a year. Medicare Advantage is often free, but has all the other problems of prior authorization and stuff. So for that reason, a lot of people are joining Medicare, look at the arithmetic there and go, well, $12,000 out of pocket if you're sick, but I'm not sick. I'm not sick. So I'm going to start with Advantage for free, or for $18 a month, and I'll get out of there because I can. I'll get out of there and go back to traditional Medicare if the MA plan won't let me see the doctors and hospitals that I want. So they think that they have that choice because nobody's talking about the fact that they're trapped. Nobody's talking about this. And you can bet your insurance agent isn't talking about it, and they don't know that they still might make that decision. It still might be the right decision based on the short-term economic issues, but they should at least know that they're signing up potentially for a trap. And they need Medigap. So why do they need Medigap? Why does this exist? Why was Medicare designed with gaps? When you were setting up a national health insurance program for seniors in 1965, why would you put those gaps, these copays and deductibles? Why would you do it that way? Well, there's a few reasons. There's 3 or 4 reasons that I'll talk about. The first one that I think some people honestly considered was what is called in economic literature the moral hazard, which is that if you give people better coverage, then they're going to go use more healthcare. They're going to go run off and, wake up in the morning and go get their third colonoscopy that week. The moral hazard. And in truth, I practiced in a setting where healthcare was free. There was no copay and deductible. And occasionally I would see somebody who would come in pretty frequently without needing to. And what I discovered was the few people that did that had something else going on that we weren't addressing. There was some domestic violence or some depression or something else. So people who do, most part, do the moral hazard, or what seems to be that, in my experience, are typically people who have something that we have failed them at and that we need to do better at. And so despite that, the solution that the folks were promoting in 1965 was skin in the game. Skin in the game. What a horrible thing to say at all, but particularly in healthcare. But the less disgusting part of description is that since we're worried about people overutilizing healthcare, if we make them pay part of the cost, then they will use less healthcare and they will become more prudent customers. Is that actually true? Well, since there is discussion about making people pay for the preventive medicine things again, which the ACA made free, there was a survey done recently looking at would people pay for these things if they had to. And here's a list of things that we probably think we want all Americans to have access to. If you are at risk for diabetes, I want you to go ahead and get screened for diabetes, because if you're not screened for it and you wind up with untreated diabetes, then you're going to get sicker and sicker and lose the ability to work and, all kinds of other consequences. So each of these things are things that, they're good. We want people to be able to do these things. And so the question was, if you had to pay for them instead of getting them really at no out-of-pocket expense, thanks to the Affordable Care Act, would you do them? Most people would stop doing these things. If people had to pay for them, smoking cessation guidance, that helps us all. The people would not pay for these things, even though we think it's good. So skin in the game, number one, interferes with people getting things that are in all of our good for them to get. But then number two, the second flaw in the skin in the game logic, I think, was Don McCann, PNHP, Dr. Don McCann, PNHP guru, one of people, we've all learned a lot from Dr. McCann, said, this about it. He said, we don't really have to worry about unleashing a stampede for free leg amputations or free liver transplants. So it's kind of a ridiculous argument to say the moral hazard, was why but I think there were people who thought that and probably still think that. Create a niche for the commercial insurance industry. So when Medicare was being enacted, the commercial insurance industry was opposed to it at first, because they thought, we got nothing to do here. So by creating a niche, by creating this opportunity for Medigap plans, they actually created allies from the commercial insurance industry. That's interesting historically, but there's a really important lesson from that. And that is, you'll hear people today saying, if you want to do Medicare for all, you're going to eliminate all these insurance companies. Isn't there a way we can create a niche for commercial insurance companies in Medicare for all? And the answer to that is absolutely there is. Absolutely there is. We could do the same thing to Medicare for all that they did to Medicare and make it crummy or crummier. We can limit coverage. We can put in copays and deduct. We can put in crummy things about Medicare for all, and then hooray, we will have created a way to preserve the commercial insurance industry. Let's not do that. Let's not do that. But then the last thing, which is hard to find writing about, but I think might have been perhaps the biggest driver, was it was part of the Southern strategy, also known as racism, which is that a 20% copay guarantees that poor Black folks wouldn't be getting medical care, right? If there's this 20% copay for outpatient insurance, for outpatient care, well, then, the medical offices that have primarily wealthier patients won't have to worry about that. So I believe that was a big part of it. And Tom Hartman described that pretty nicely in his book, The Hidden History of American Healthcare. So I'd recommend having a look at that. So we've created this niche for Medigap, perhaps in part for all those reasons, but perhaps in part to make the insurance industry happy with us. And so I showed you that traditional Medicare has 2% overhead. The profiteers and Medicare Advantage have a 15% overhead and profit, and the Medicare supplemental plans have a 22% overhead and profit. Medicare Medigap plans, I should say that more clearly, Medicare supplemental policies is a synonym with Medigap policies. So Medicare supplementals, Medigap have a 22% overhead reported data, overhead and profit. So I pay $400 a month for my Medigap plan for myself and my wife, $400 or $4,800 a year. So 22% of that means I am personally paying overhead and profit more than $1,000 to Medigap companies every year. And I can think of much better things to do. I would donate that $1,000 to PNHP, for example, as you could perhaps, or to Healthcare Now. Okay, so that's Medicare Advantage. We've kind of unpacked it. Here it is, growing to now roughly 50%. But we've not, frankly, until recently, had our eye as much on traditional Medicare as the investment community has. So the investment community has, until recently, not had much that they can do with Medicare, with traditional Medicare, and they figured out a way to get something to do with it. So here's the simplest of cartoons, right? There's us in traditional Medicare on the green line on the top, which has some administrators, but no real profiteers. And then half of us are in Medicare Advantage. But there's this new thing afoot called ACO Reach, which is the new branding name for what you may have heard of last year as direct contracting, or DCE. And ACO Reach was intended to capture everybody for traditional Medicare, ACO Reach, or something like ACO Reach. They wanted to put literally everybody from traditional Medicare in ACO Reach or something like it by the year 2030, and really no longer have what I think of as traditional Medicare. So what is ACO Reach? Medicare is, even today, assigning people in traditional Medicare into one of these new outfits called a Reach ACO, into one of these new outfits if Medicare determines that your primary care physician, based on medical bills that have been sent into Medicare, if Medicare determines that your primary care physician has a contract with one of these ACO Reaches, they will assign you to that physician's ACO Reach without asking you. They don't need your permission to put you into one of these things. And they might tell you they're supposed to send you a nice letter, which, looks kind of insurance-y, and it says no action required. So, most of us aren't as good at reading things like that as perhaps we should, but they're assigning you without your full knowledge or certainly consent. And then it's not exactly like Medicare Advantage, but it's similar to Medicare Advantage in that Medicare then, rather than paying doctors and hospitals directly, Medicare pays the Reach ACO for the range of services that the Reach ACO has contracted in a secret way with Medicare. There's a range of services that organization contracts with Medicare, and Medicare then prepays them. So it's the same business imperative that was with the HMO Act in 1973, that was with Medicare Advantage, and now with Reach ACOs. It's the same business imperative, introducing a for-profit, profiteering third-party intermediary that makes money off of this by getting you less healthcare services, and then they can retain more. That's just not what these other countries have found to do. If you learn all this and you decide you don't like it and you want to get out, Medicare has made it very clear. Of course you can get out. You're not in there for life. You can get out. All you have to do is find a new primary care physician. That's really unbelievably rude and insulting to say that at so many levels. And by the way, if they succeed at getting everybody in one of these, there won't be any new primary care physician who's not in one of these. And this has been happening and is happening without Congress. This little tiny arm within Medicare was created as part of the Affordable Care Act, actually, and given the power to do programs like this independently, without telling Congress that they're doing it, without getting Congress's approval. So without congressional knowledge, they've been transforming Medicare from a lovely model into one that's ripe for profiteering. And in fact, a handful of us from PNHP went to Congress and told them about this, and they were dumbfounded by it. As of now, today, there are 2.1 million Medicare members have been assigned to one of these. They were on track to have 30 million people assigned to something like this by the year 2030. And frankly, our advocacy work has been successful here, so that Medicare has announced that because of the public outcry, because of groups like Healthcare Now and PNHP and others raising the alarm bells and getting Congress to know about it, and then having Congress with Representative Diapol and many others write letters to Medicare about their disdain for this model. Medicare announced a few weeks ago that no, we're not going to have 30 million people in a program like this. Instead, we're only going to have this program will not grow beyond the 2 million that it has today, and we're not going to take new organizations. So, hooray! And that doesn't mean the fight is over. This is what they said. They could go back on that word. They could do Reach 2.0 and do something different. Next year, they could take Reach and sprinkle it across the rest of Medicare. They have a this is not an ending. This is not over. We need to stay alert and vigilant and active. But yeah, we don't get these victories too often, so we should celebrate it. So I showed you that this is why we're concerned about it. In part, I showed you these egregious numbers with Medigap having as much as 22% overhead and profit. Medicare Reach, ACO reaches, if they're prepaid, as I said, on a capitated basis per month per person, and if they spend 25% less than their capitation, they keep all of that. They keep all of the first 25% that they don't spend on healthcare, and it can go even higher than that if they cut services by more than that. So it's just perfect for profiteering. Why we would set this up, I don't know. So these profiteers, this privatization must be stopped, must be driven back. We must protect traditional Medicare. We must protect Medicare if we want to get to Medicare for all. And that means, number one, we need to guard against Reach coming back, being reincarnated. We have to, stay vigilant about that. It also means we need to sour the milk. We need to cut off the business case. We're not going to get a law passed that says Medicare Advantage is over tomorrow. That's a pretty heavy lift. But we need to make the business case for Medicare Advantage increasingly unattractive to the investment community. That means, first off, it's absurd that we're overpaying them in the ways that I said. So we need to, get Congress to step up and say, hey, we're not going to overpay you. We need to level this playing field. You don't get any extra money. And when there are companies that are guilty of fraud or other malfeasance, they should not be allowed to participate. That's not enough of a strategy, because for many people, Medicare Advantage today does offer short-term financial benefit, as I alluded to, $5,000 a year versus free. If you just did this, that's not, we can't put people in the middle of our policy fights. So instead, we need to also sweeten the juice, not the right language, but sweeten the juice of traditional Medicare. We need to make traditional Medicare better. So just as we're fighting against Medicare Advantage, we simultaneously have to be doing some of the things in improved Medicare for all. You've heard us typically say improved Medicare for all. And that means, number one, eliminate the copays and deductibles. If you do that, then you don't have to learn all this arcane nonsense of Medigap. So we need to make Medicare better by eliminating copays and deductibles, or at least putting in a very low out-of-pocket maximum, but ideally eliminating it, and then cover the things that people can't get unless they go into Medicare Advantage. So cover pharmacy, all these other things. So that's what we need to do. It's tough. Our opposition is formidable, but it is not invincible. We can win this. The opposition against getting Medicare enacted in 1965 was formidable, but we should hang our hat on that. All the same barriers are there, and in 1965 it was enacted. Other things have been won. It takes a fight. Our opposition is formidable, but not invincible, as Dixon from PNHP said. Last thing, there's this terrific website with a growing bit of information about Medicare Advantage and about Reach and a few other things. Go to protectmedicare.net. And thanks again to Healthcare Now for having me, and thanks for watching this.